Good morning, everyone, and thank you once again for joining. We've got a hot topic with a hot presenter, Dr. Duncan Webster. Many of you know Duncan, but for those of you who don't, here's a little background on him. Originally a St. Johnner, did his undergrad studies at Mount A, where he did a combined BSc and a BA. Interestingly, the BA was in philosophy and religion, and then he went on from there to do a master's in philosophy at UNB. He did his MD at Dal and then went out to U of A, where he did his internal medicine residency and his infectious disease fellowship. He came back to Dal and did further fellowship training in medical microbiology. And now he is on staff here at the St. John Regional Hospital as one of our premier infectious disease specialists. He is not only a clinician, he is an avid researcher and truly fits the bill of a clinician scientist. And then last but not least, he's truly a great all-around guy, and we're just so fortunate to have him as one of our colleagues. So I wanted him to kind of touch base, especially where COVID really hasn't passed as a topic of interest, to talk to us. Initially, I'd really wanted to talk about just vaccines, but he insisted, and rightfully so, on kind of splitting it up into two back-to-back talks this week and next week. The first one would be on logic and molecular diagnostics. And then next week, we'll be talking about vaccines, and all along, we'll kind of touch on variants. So Duncan, without further ado, I'll pass it over to you.
Awesome. Thanks very much, Ansar. You guys can hear me okay?
Yep.
Great. Yeah, so really excited to do this talk. I think a really important topic. And as I mentioned, there was a case recently that we'll run through as one of two cases to kind of highlight what is going on with regards to the diagnostics around SARS-CoV-2. So let's see, page. Here we go. So of course, in starting, I do need to acknowledge that I live and work on the unsurrendered and unceded territory and traditional lands of Wolastoqey. So happy to live here. I'll be here till I die. And I think one of the concepts I want to try to get across in this as well is the concept of the system that we've developed with regards to SARS-CoV and COVID-19. We as this was all unfolding about a year ago, a structure was put in place to help to respond to the situation, and there were a lot of key points. There was talk about flattening the curve, and really the big thing was to make sure the healthcare system was not overwhelmed. So a series of different, a structure was put in place, and a series of color codes was also put in place. And one of the things I think is really important to understand that recently there was a shift in the colors. The colors were suddenly shifted. The rest of the structure didn't change, but what the colors meant and how we were going to respond changed. And it's a bit like taking a house and moving part of it. If the house is moved off the foundation, cracks will form. And I think that's pretty evident with what a lot of what we've been seeing. And certainly the diagnostics are an example of that, which I think are pretty clear, and I'll show you. Now I know we don't have a lot of time, so I'm going to really run through this. I want to try to be done by about 8:20, so we'll have about 10 minutes to chat. So I'm going to go through a lot of these concepts very, very quickly, and I apologize for the speed, but we can go back if need be. The logic piece comes into this equation. So the positive predictive value. The positive predictive value of any test that we do is, it depends on the sensitivity and the specificity of said test, and of course the prevalence of the specific illness that you're trying to diagnose. And that can change, and as the prevalence changes, the positive predictive value of a given test changes. So we'll come back to this equation. Okay, so two cases. The first case, so January 30th, when was that? January 30th was, I guess not last Saturday, but the Saturday before. So a 58-year-old woman comes into the St. John Regional Hospital. She's from Zone 2. She's got no respiratory signs or symptoms and a normal x-ray. She has abdominal pain, and the CT very clearly demonstrates acute appendicitis. So there was no doubt about the diagnosis. And bearing in mind it's Zone 2, at that time there had been no COVID-19 cases for a couple weeks, and there had been no community spread for, geez, to be honest, I can't tell you when we had community spread in Zone 2. It was before the new year. So as part of the current guidelines, so our policies, we're in phase orange. So phase orange tells us that all pre-ops get screening. Because this is deemed an emergent surgery, we can't wait for the turnaround time through the George Dumont. So GeneXpert rapid test is performed and it comes back positive. All right, so we'll come back to that case. The second case is one that the cardiovascular group will be more familiar with. So February 2nd, which would have been Tuesday, so just over a week ago, 50-year-old farmer from zone 3. They had some cluster of cases there, but they were almost 2 weeks old. This gentleman had fatigue and shortness of breath for about a week, goes into the emergency department in Upper River Valley, tropes high, 1700, T-wave inversions, I'm told. He ends up getting transferred to the St. John Regional Hospital to the cardiac unit. And once down here, word comes that, in fact, he had been swabbed for COVID at Upper River Valley Hospital. Again, the rapid swab, GeneXpert, again, it's positive. Now, when we look closely at those results, there's 2 targets, and I'm going to talk a little bit more about the tests in detail, albeit quickly. The 2 targets, one of the targets is the E gene. It's 0. There's no amplicon generated. The second is the nucleocapsid 2 gene, and it has a CT value of 42.9, which is very high. Nonetheless, this is deemed a positive test by the recommendations on how to interpret this test on this platform. So there's 2 cases, and we'll come back to both of those. Okay, so first of all, in terms of talking about I want to just run quickly through the different test modalities that we have that we're using. So the PCR, polymerase chain reaction. So the reverse transcriptase PCR. So this is, when we refer to this is the traditional PCR technology that the George Dumont is running. And the primer target is the E gene. It's very sensitive and very specific. Turnaround time, as we all know, is about 36 to 48 hours, depending on where you are. A little bit shorter in Moncton. And the reason for that long turnaround time is not because it takes that long to run the test, but the logistics of getting the test in the lab, getting them on runs up to the George Dumont, and then waiting for the batched runs at the Dumont. The other concept I think that is really important to demonstrate here is this concept of the cycle threshold. So in this graph, and this is a concept that I really do want people to try to understand. And those 42.9 and the 0 that in the case, this is what we're talking about, cycle threshold. So what that means is the PCR reaction, I'm not going to go into detail about it, but just understand that it will generate amplicons when the primers recognize the target site. And once it hits a threshold, it will be reported as positive. Generally, if you've got a meaningful amount of virus, you're going to have a positive result around 20, usually less than 30 cycles. Okay, so that's going to tell you you've got a reasonable amount of virus. If you're up over 30, you've got a very low amount of virus. It's taking a lot of cycles for this process to run through to generate detectable amplicon. And it's a logarithmic growth with regards to amplicon generation. And when you're getting up, well over 30 and 40, I mean, there's barely virus there. And when you get up to the range of high, mid to high 30s and 40, you're generally talking about an amount of virus that it's generally not associated with communicable disease. And if it is, it's generally not even viable virus. It is often just remnant RNA non-viable virus. So when you get values up in the mid to high 30s and 40s, generally that's what it means. Very low amount of virus, if viable at all. Okay, a lot of people talk about the rapid test. When people are talking about the rapid test, this is what they're talking about. It's a GeneXpert. GeneXpert is the platform. It's also real-time RT-PCR. 2 primer targets, the nucleocapsid gene, the E gene, again, highly sensitive and specific. The turnaround time is 45 minutes, and most labs have their own GeneXpert, all the central labs in the province. The availability, when we're talking recently about pulling back and not using too many tests, this is what we're talking about. there's not a lot of these kits remaining. So currently, as of yesterday morning, we had 41 kits remaining, and it's a limited resource, daily inventory counts. There are no more shipments of this plant. However, as disastrous as that does sound, there is a combined kit, same test, GeneXpert. It has the SARS-CoV-2 testing ability, but it combines it with influenza A and B and RSV. So same concept, same genes to target, same high sensitivity and specificity. Turnaround time is actually even better than the SARS-CoV-2 alone, 36-minute time run. We are getting 150 of these every 3 weeks at the present time. As of yesterday, we had 145 of these. So that may sound like a lot, but when we're running through these, they don't last. So we still need to be very careful with how we're using these. The province has instituted protocols under which these can be used. And I think most of us are familiar with these. People coming into to hospital for admission with clinically suspected COVID-19, entering into the ICU, the pediatric unit, psychiatric ward. And this is also used for the pre-ops if we don't have time to use the traditional PCR with its longer turnaround time. The Abbott ID Now is something that if you're not familiar with, you'll start to hear a bit about it. This is, you may hear about some peripheral sites such as St. Stephen running point of care tests. This is what they're using, the Abbott ID Now. It is not PCR, it is a different technology called isothermal RNA amplification. It has a different target, which is the SARS-CoV-2 RNA polymerase. The sensitivity and specificity are a bit suspect. If people have symptoms within 7 days or less than 7 days of symptoms and symptomatic, then it actually, from a Quebec validation study, the sensitivity and specificity actually don't look too bad. Although looking at the report, it is not clear as to when this was done. And of course, prevalence impacts positive and negative predictive value. But I would say it's probably safe to say throughout the pandemic, the prevalence in Quebec has been, even at its low point, has been probably similar to us at our highest point, if not higher. So I think still reasonable numbers there. Turnaround time very quick. We are going to start using this in some of the more central hospitals. So as an example, in St. John, we will begin to use this test in our lab. And then once staff are trained in the emergency department, it will be transitioned to the emergency department. Another test, and I've got ones in red highlighted if they're relevant to the cases we're going to talk about. The BioFire is going to come up again when we refer back to these tests. This is another molecular PCR test that we have. It's less sensitive than the GeneXpert. There was a comparative study using dilutional series. So as they diluted out the amount of virus, where the GeneXpert was still able to detect virus, the BioFire seemed a little less sensitive, but still highly sensitive. 45-minute runtime. And the current plan from the powers that be is to use this if we have individuals who are being admitted with suspect COVID-19 going to the ICU, 4A South, or immunocompromised going to 5A South. So 4A South pediatrics, 5A South oncology. The reason for these sites specifically is that this BioFire panel has 19 respiratory targets. And when I say 19 respiratory targets, I don't mean 19 targets to identify SARS-CoV-2.
Yeah.
I mean, there are 19 pathogens that it can detect. So this is a list. So you can see if somebody's going to the ICU or a pediatric patient, it may be useful to simultaneously check for other things, including human metapneumovirus, influenza, mycoplasma, other respiratory pathogens. So that's the rationale for using it in for those particular situations. The Spartan BioScience, so another PCR test. It's actually PCR point of care. This is, people would have heard a lot about a Canadian Ottawa-based technology, and this is the Spartan. It was approved early in the pandemic, but then approval was revoked, and just late last month it was reapproved. There's not a lot of data with regards to its sensitivity and specificity, and going online, there's really, details are very, very sparse. and it's not currently being used in New Brunswick, but it is something that we may see come our way in the months to come. Last test I'm going to refer to, this is not a molecular test. This is a rapid antigen test. You can think of it a little bit like, say, a pregnancy test, where you're going to take a nasopharyngeal swab and you're going to get specimen into a well, and it will run down a laminar flow assay. And just like a pregnancy test, a control will read positive, and a test will read positive if you've got detectable nucleocapsid antigen. It's a point of care test, 15 minutes. It is really only appropriate to be used if people are symptomatic and symptomatic less than 7 days. You can see the sensitivity is very poor. And if you talk about using it in people who have symptoms for greater than 7 days, the sensitivity actually falls to just over 30%. So you need to be very careful with how you use this, because a negative test can provide a lot of false reassurance. There's a role for this in certain situations, but you do want to be very careful with how you use it. Okay, so I've got about 5 minutes until we want to have time for discussion. So I'm gonna park those tests there, and we can come back to chat about those if people so desire. But I just want to come back to these tests, or to the cases rather. Okay, so firstly, case number 1. So the woman who had come in with acute appendicitis, her COVID-19 test came back as positive as per our GeneXpert. So what does that mean? As I mentioned initially, some numbers to go along with these gene targets, these CT values. And having had a chance to talk quickly about the CT values, what does this really mean? Well, what it means is that there was no detectable E gene and very minimal N2 gene, a very high cycle threshold value. So this is likely, there's likely not viable virus here. And to clarify this, we did send the swab up to the George Dumont for the reverse transcriptase PCR, and it was negative. So what do we make of that? Well, I think it's important to come back to this logical approach to testing. What was the positive predictive value of that GeneXpert result in the first place? So when we drill down, we know the sensitivity and the specificity of the test, and being extremely generous in assuming that every positive case in our zone from the start of the pandemic was still active and possibly transmissible in our community, we could calculate a positive predictive value. The positive predictive value of that GeneXpert test result was 3.8%. So what that means is that the probability that it was actually a false positive was 96.2%. So you could ask, if that's how valuable and how meaningful a positive result is, why are we doing this test? I would ask the same question. We're doing the test because we're in orange, although our current situation in zone 2, our system was designed as if we're in yellow. So when they shifted the colors and the structure remained the same, cracks show. We're doing tests that have no meaningful value. The probability that individual with no epi-link to any cases, no signs or symptoms of COVID-19, and a very clear diagnosis to explain her symptoms, there was no role for doing testing in that case. And all the testing did was impact your management and cause a lot of confusion. So the logic of doing tests like this in our current situation in our zone is highly questionable. Okay. Coming back to, sorry, the other thing I should mention about that first case is as well to help to support that serology was done. And this woman's serology was negative. So again, that does support a false positive result. Okay, our second case, and there's a little more detail in this, so I'm going to take a few minutes. So 55-year-old farmer, as we talked about, so he had come down to St. John from Upper River Valley. The GeneXpert had been collected at Upper River Valley. Again, this questionable positive result, and it then underwent some further tests. So when the patient arrived in St. John, the Upper River Valley test had been collected at 6 o'clock at night, and a second swab was collected upon arrival and hearing of the GeneXpert result performed at the deck, and a second swab was collected at 11 o'clock at night. So I'm going to just kind of run through a series of events. My understanding was that this patient, aside from the shortness of breath and fatigue for a week, really this appeared to be an acute coronary event, and the cardiac cath, I think, supported that. So there was pretty clear explanation for what was going on. But again, keeping an open mind to things. So the first swab that was done, collected at Upper River Valley at 6 o'clock, run on the GeneXpert at the DEC in Fredericton. We get this result. The George Dumont, the same swab was sent along to the George Dumont, and it was found to be negative by their PCR. With that negative result, they thought, well, just why don't we run it on our GeneXpert? So it gets run on the GeneXpert at the George Dumont. Well, they get a slightly different result, still a positive result, but this kind of lays into question, okay, well, this is arguably more meaningful, more suggestive of a positive. So let's follow up with some additional things. So the second swab done when the patient was at the St. John Regional Hospital at 11 o'clock. This swab was sent up to the George Dumont directly. The RT-PCR done, negative. So we're getting a lot of different conflicting results here. That specimen that was collected at Upper River Valley at 6 o'clock, back at the DEC, they pull it out of their freezer. Now, frozen specimens are not optimal for the biofire, which we've talked about, but their result comes off as negative. So we've got a lot of conflicting results here. What's going on? How do we make sense of this? So meanwhile, in the background, public health is doing some work. Very helpful. They recognize that the patient's wife actually works at a car dealership north of Fredericton. And there had been a couple cases of SARS-CoV-2, COVID-19 at the dealership a couple weeks before. Although the wife was asymptomatic, she gets swabbed. Her swab is run on the GeneXpert at the DEC. This is that rapid test. She gets very similar results to the initial testing of the husband. So no E gene detected, very, very high CT value for the N2. Serology is collected. It was supposed to be run yesterday. So we'll come back to that. Again, just trying to make sense of everything. We opted on February the 4th. So the first test was collected on a Tuesday. This would have been Thursday. We collected another swab to see if there was any evolution. We ran it on our GeneXpert at the St. John Regional Hospital. We get similar results. It's still technically a positive. Now, this is a couple days later. We would expect if this was an early evolving case, given logarithmic growth of virus, that should have really converted to very low CT values. We didn't see that, but again, it's still a positive. There's still a lack of clarity here. So we run this on the biofire in St. John. Remember, the biofire at the DEC had been negative. Our biofire says it's positive. Our specimen wasn't frozen, so probably a slightly better specimen. We opted on Saturday to repeat the test because now we're several days out. And if there was truly early evolving infection, we absolutely would have had a positive result at this point in time. And then the PCR on this was negative. So ultimately, I'll just mention the serology that was supposed to be back run yesterday. That's my cricket chirping because that's all we get back. It hasn't been run yet. The bottom line is when looking at any diagnostic, you need to take, with a viral infection, you need to look at the viral parameters. You need to look at the lab diagnostics, the clinical picture, and the epidemiology. And overall, I would argue that in this case, given the EpiLink, there probably was, this patient probably did have SARS-CoV-2, although the way that we saw the CT values evolve, this would have been a non-communicable, likely non-viable virus detected in this patient. And so you could, in essence, call this a false positive. So I'm going to stop there, but just to say that, the problem I do see is that, again, we've shifted colors without recognizing that the foundation is set up for a different structure. So cracks are showing. And anyway, I'm going to stop there because I think there probably is a lot of thoughts or questions or comments about the diagnostics and the cases.
Duncan, thanks so much. That's awesome. And so I just want to kind of touch base on a couple of questions, and maybe Saurabh, why don't you unmute yourself and why don't you just ask your questions?
Okay, can you hear me? So Duncan, two questions. On some of your tests, you talked about validating for pooling, and is that like testing groups of people, like runoff water from a retirement home or something? Is that what?
Well, so what it would mean would be for the pre-ops is when we were running very low on kits, and a lot of the pre-ops, arguably, they're asymptomatic. There's no epilink. There's no cases in the community. The pre-test probability is so low, so they're asymptomatic. So we can pool in those kits four specimens. So it just helps us to preserve. So you're going to take specimens that you can predict are going to be negative, run them all. If we did get a positive, we'd have to take them all and run them individually again. It just allows for conservation of a limited resource.
Okay. My second question then, and I guess this relates to the community prevalence. Like you did a PP positive predictive value for that appendicitis case, the first case, and the positive predictive value was terrible. It was like 4%. So what if we wanted a decent positive predictive value of like at least 50%, what kind of community prevalence do you think we'd be seeing, or do we need to have? And we seem to be quite far from that even as a province.
Yeah, well, because technically the way things were designed, we're really in yellow phase, although I guess yellow doesn't exist anymore, I'm told. But technically we're really in yellow phase. So these pre-op tests wouldn't be done. That was never the plan. It didn't make sense to do it. But we're in orange, which it's by policy required. I mean, you would need, in fact, the prevalence would really need to be much higher, well over 10%, if not 20, 25% to have a meaningful positive predictive value. But at least you would want to have some sort of epilink, some sort of concern, some sort of community spread where testing makes sense. I think that you're going to hit a huge gray zone where you can argue the relevance and the meaning. But I think on one end, you can argue very clearly that when you have no community spread, no contacts, no signs, symptoms of illness compatible with disease, a positive test is just going to add a lot of confusion.
So should we not, so I guess then, should we not be doing random OR swabs unless we're in the new red, which would be like real
what
community
I would
spread?
suggest, yeah, I mean, what I would suggest, if you think back to before Christmas, right, like things were working well and we weren't, we were in yellow. And when you were in yellow, there's no community spread, case counts are low, public health is able to maintain and do appropriate contact tracing to keep things in check. That's what yellow is, and that's where we are now. There's no role for doing pre-op testing when we're in yellow. Everybody was comfortable with that before Christmas. We should still be comfortable with it now. The science hasn't changed. So it's really, I wouldn't say we need to create more colors and more definitions or adjust. To go back to a system that worked, I would argue, made sense.
Craig, and then JF.
Thanks, Duncan. This is great. Two quick questions. Is there a difference in the timeline of E and N2 expression during an illness?
No, they would be expressed the same. Yeah, the envelope is going to be a little more available without appropriate, even with less efficient extraction. The EG may still be more available for targeting, but really they're both genes that are going to be within inside the capsid. So there's not going to be any difference in that regard.
And also, I've read in the media that apparently Canada has a large supply of rapid tests. Is that true? And if that's true, why aren't we using them? Why don't we have them?
Yeah, I guess large supply is a bit it's a bit subjective what you mean by large, because you could say, well, we're getting with the combined cartridge, so the rapid test, which is highly sensitive and specific. We can have a result in 36 minutes once we get it on the platform. We're getting 166 to our own hospital every 3 weeks. So you could say that's a pretty good supply. And it is. And equally, our BioFire, we have a large supply of. So you could argue that we do have a large supply. But when you use a lot of a large supply, it dwindles quickly.
JF, thanks, Craig.
Yeah, thank you, Duncan. I think you highlight quite specifically the way we're sort of caught in the protocols that we follow, and they don't really make sense, but we're sort of stuck in them. And you are, if two comments I would have is the predictive value, the positive predictive value of a population. I agree, you sort of think of the province, but you can narrow that down, obviously, which you're questioning. So if you have a patient that's traveling a lot, that positive predictive value would be different. That's my first comment. And the second one is, why don't you guys report on the thousands of tests that we've done preoperatively and show that there is really nobody that you've ever picked out that have made a difference? Would that then potentially change policy? Like, you must have data on thousands of these tests that have done preoperatively for patients. I can't imagine a single one that I remember of that changed what we did.
Yeah.
Anyways.
Great points, JF. I agree wholeheartedly. Yeah, you're right. There individual situations. So when we looked at the positive predictive value that I reported, that was specifically for zone 2. But you can certainly refine that, and we have the ability to do it. If we had a patient coming today from Edmundston, you could have a very refined positive predictive value. You could even pare it down to, were they in a nursing home? What's the prevalence within a nursing home? All these things, absolutely. And it can be done. It can be done very easily. But there's not great communication, at least not with our lab. We don't get the information that we need. And even if we did have that information, we don't have the ability to change the policies. So I had an anesthetist who wanted a swab the other day outside of the OR to do a sedation, and insisted that the policy said that they should have a rapid test. The biology didn't matter, and I have no ground to stand on because I don't make the policy and I don't get data. You're absolutely right. And along the data lines, the data also that you suggest that we could talk about the pre-op swabs, 100%. We absolutely could put that out. When I say we, I'm not part of it. But to my knowledge, that was the first the first positive pre-op test we had. And again, we saw it was a positive predictive value, made no sense in the setting. It was a false positive. I do know of one up in Moncton. I don't know the outcome. This was earlier on in the pandemic, but there are a lot of things that could be refined, can be refined, should be refined. But I'm just sitting here in my office.
I understand.
Yeah, you're doing great. And thank you so much. I think that's hugely informative. It kind of sheds a little bit of light even just on how we're treating travelers coming in from out of country, out of province with a rapid swab, and the weight that's being put on that or the lack thereof. And I think, and just in terms of how we deal with the OR, I think it behooves us at the end of the day, it still gets back to screening, and exercising the basic principles of social distancing, mask wearing, and hand washing. I think it all comes back to that. We can't put our hat entirely on a test and assume that that's the driver of how it is that we behave during this pandemic. Duncan, I can't wait for next week, where we'll talk a little bit more about vaccines and kind of build on some of what you've talked about this week. And obviously we'll touch on the variant as well. Hugely informative. Obviously you can tell from the attendance that this is a popular topic. And like I said, onwards and upwards until next week. Thank you so much.
Thanks very much, guys. Have a good day.
Thank you.